When I first got asked about presenting here to a conference about sleep disorders and trouble sleeping, I was thinking, have you heard my lecture? Did I put enough people to sleep that you really want me here? But then it became clear that urinary problems are prevalent in Parkinson's disease and, of course, disruption of your night's sleep with having to go to the bathroom happens to be one of the worst symptoms of all. So I'm going to go pretty quickly. I have a lot of slides. I think we're going to save questions for later, but I'm happy to answer anything possible. Patients with Parkinson's disease are susceptible to have everything else that anybody else has, in addition to the problems with Parkinson's. If you get symptoms, you're probably thinking it's my Parkinson's disease, and it may not be. We, as urologists, have to sort of break it apart to decide which symptoms we can treat one way and which symptoms that we can treat another way. And here is a picture of the urinary tract. By the way, urologists deal with the urinary tract in both men and women and the genital tract in men, generally. Now, urology, it starts with a U, and most of you go to a neurologist. Of course, you know what the N stands for, and that's knowledge. Anyway, the upper urinary tract is the kidneys and the tubes that carry the urine down, and those are called the ureters. But most patients have symptoms from lower urinary tracts, which is basically the bladder and the urethra. Now, here's another picture showing the bladder and urethra. The problem with this picture is this is incorrect in that it doesn't fill up from the bottom and then there's an air-urine interface. It's not a globe, it's like a balloon. When you inflate a balloon, it inflates. When you deflate a balloon, it drops down. So there's really not this interface. But this is the area that patients have most symptoms from. Most of you all know your potential symptoms that you can have with Parkinson's disease. You have the muscle disorders, cardiovascular problems, gastrointestinal problems, constipation is common, sialorrhea. With regard to the skin, there's sweating and seborrhea. Of course, neuropsychiatric depression and apathy. But I'm going to be talking about the genitourinary symptoms, which include both voiding problems and sexual dysfunction. And as you can see there, over 65% of men with Parkinson's disease have significant problems compared to the 37%, or about half, age-matched controls. With women, it says 36%, but I'm not convinced of that number. What are the common voiding symptoms that patients complain of? Well, the most is frequency. Now, frequency as a symptom alone tells the urologist to exclude nothing because frequency is the most common symptom we deal with. Frequency can be in Parkinson's disease, it can be in infection, it can be in tumors, it can be in stones. So a patient comes in with frequency, we can't eliminate anything from that. Urgency, however, is that sense when you gotta go, you gotta go. And if you gotta go when you gotta go and you don't make it to where you wanna go, then you end up with urgent continence. Nocturia is, I think, one of the other worst symptoms other than the urgency and urgent continence, and that is waking up at night. So you're sleeping well and your sleep is disturbed because you're awakened by your bladder saying, take me to the bathroom. And that's really, it's this vicious cycle. You don't get a good night's sleep, and then the next day is bad, and it just goes on. And it causes fatigue and a loss of quality of life. Of course, we have other things like weak stream and dribbling, and also a sensation that you haven't emptied. You go to the bathroom, and you think you're done, and 20 minutes later you go, I got to go again. So those are common symptoms that urologists see. Now, added on to that, when a Parkinson's patient comes and sees me, they're usually on 1 or 2 or maybe more medications. Now, this is an older slide, but you can see some of the medications that some of you might be on, Mirapex and Sinemet. They have their own set of symptoms. Now, one of the things that I don't like to do is a patient comes in with complaints and they have symptoms. Well, I don't like to treat those symptoms if I'm going to end up causing a new set of symptoms. It's like gridlock. You're moving, one patient from one specialty to another. and I'll talk a little bit more about the side effects of therapy. But it doesn't help the patient if they come in with 3 symptoms of urinary tract problems and you treat those, but now they have gastrointestinal and ophthalmic problems. That doesn't make any sense. You don't want to just move them off to another doctor with medication. Anyway, you can see that some of these medications do have side effects. A couple of them help basically prevent you from emptying the bladder, and the others can cause either frequency and/or incontinence, where you're leaking. By the way, incontinence is not a diagnosis, that's a symptom. The type of incontinence is the diagnosis, whether it's stress incontinence or urgency incontinence, which we talked about, or often we see mixed incontinence. So when we do an evaluation, a patient comes in and I'll ask them, tell me your symptoms, how long has it been going? Often I say to them, come back or bring in a diary of their urinary pattern. In other words, write down every time in a couple or 3-day period that they go to the bathroom. And they come in with these little yellow pads of paper, 1235 and 140 and 330, and we count them up, and we also try to determine how much, not only how many times they urinate, but how much they're urinating. We look at, is the quality of life affected by their urinary tract symptoms? Then I'll do a regular examination, and often a neurologic examination, although I'm a urologist, I'm not a neurologist. I'm not going to stick you with pins and run all sorts of stuff, just sort of a global thing. Obviously, we look at the urine and a culture. We're looking for any blood or any evidence of infection. And then we do renal function tests, which is basically a kidney function to make sure that the kidneys are okay. The reason why that is important is if the lower tract, and you remember that slide that I showed, the bladder, if there's dysfunction, which we're going to talk about in a moment, if there's dysfunction of the lower urinary tract, it can translate to problems with blockage or infection in the kidneys, and that can be a big problem. Just an aside, in the 70s, before what we call intermittent catheterization was sort of discovered or described, about 60 to 70% of people with neurologic conditions, meaning stroke patients, Parkinson's disease, multiple sclerosis, diabetes, motor vehicle accidents, all those different things. Between 60 and 70% of those patients, their cause of death was often attributed to a urinary cause, infection or renal failure. Well, we have better imaging that's safe, we have better ways to treat infection, and we have better ways to maintain lower urinary tract health, which then translates to better upper tract health. So we don't see that anymore. Often we do x-rays. I'm a big fan of ultrasound. It's cheap, it's non-invasive, there's no radiation. Endoscopy is where we would look inside the bladder. And then something called urodynamics, which is a fancy word to describe urologic torture. No, not really. We just, we put a lot of catheters, I have a picture, and we measure several different things, which I'll describe. Now, this is a slide of the neurologic system. As you can see, it's very complicated. The only thing I'll let you get from this slide is there's the brain and the spinal cord and the nerves that go to the bladder. The bladder is the recipient of a lot of diseases. So we are the effect. Parkinson's disease is one of the causes of the problems. Now, I don't treat Parkinson's disease. I treat bladder problems. So I'm treating the effect. And often I can be very, very effective, and then a year later it's not effective anymore because Parkinson's disease is unfortunately a progressive disease. But you can understand from this picture is that we're on the dead end. We're on the far end of everything. So the disease of Parkinson's disease is here. If you have a stroke, it could be here. If you have a spinal cord injury or multiple sclerosis, anywhere of the transmission of neurologic impulses from the brain to the spinal cord and right into the bladder is going to affect us. And it's my job to treat those side effects. Here again is the lower urinary tract. We're talking about the bladder. And in men, there's this thing that basically the field of urology is built around. It's called the prostate. And then in women, it's the urethra. The prostate sort of started the field of urology in that there's two major institutes in the East Coast. One is in New York, and one is in Baltimore at Johns Hopkins, and it's called the Brady Institute, and I think they were started in the early 1900s. And they were endowed with a lot of money by Diamond Jim Brady, who was a big gambler, and apparently he had a few problems with, I think, sexually transmitted diseases. Why Baltimore and New York? Because Baltimore and New York were the major centers for horse racing. And he used to go between New York and Baltimore, where they run, I guess, the Preakness. So he endowed both those places. So urology sort of grew from Diamond Jim Brady. So micturition is basically a fancy word for the urinary cycle. And it includes bladder filling and storage. In other words, the urine comes down into the bladder. The bladder's got to fill and hold the urine. There's two things we look at. The reservoir, which is the bladder. The bladder's got to be able to fill, and you have normal sensation, and absence of involuntary contractions. In other words, absence that the bladder's going to contract without you participating in it. In fact, a lot of neurologic diseases, you could be sitting in a movie and you know you got to go, but you can hold it because you have the capability of inhibition with your thought on your bladder. The problem with a lot of neurologic conditions is the communication from the brain down to the bladder is somewhat disrupted. So those bladders don't have that inhibition and they just go off on their own. And that's called hyperreflexia or instability. So we have the reservoir, which is filling nicely until it gets to a capacity. And then we have an outlet, which would be the urethra or the prostate, which is closed during the filling phase. That leads to continence. In other words, you're not leaking. You're able to fill without the outflow leaking. Now, once you're done and you're full, now you have to empty. So it's basically fill and empty. Urology is very easy. I took the afternoon course and I became a urologist. I was going to check off heating and air conditioning, and I sort of wish I did. Anyway, urine emptying requirements. Again, we're back at the reservoir. So now this reservoir was full of urine, and you want coordinated bladder contractions that are strong enough to push out the urine, and you want an outlet, either the prostate or the urethra, not to have any blockage. And one of the most common things that we deal with is prostatic enlargement, which is a blockage. And then you want the tightness of the outlet, the urethra or the area of the prostate, to relax as the bladder is contracting and evacuating the urine. So it's very easy. You have filling with the outlet closed. You have emptying, which is the bladder contracting with the outlet open. And you have control of all this. That's a normal micturition or voiding cycle. This is basically a very simplified but clear way to think about voiding dysfunction or voiding problems. You either can't hold it or you can't empty. Now, often the symptoms are the same, such as incontinence. People say, well, you can't store it, so you're incontinent. But if you can't empty, what happens is sometimes the bladder is overfull and it continuously releases an ounce here and an ounce there. So even though they're two opposite problems, you can have the same symptom. That's why you would need to see someone like myself, a urologist, to determine which is going on. Here's your symptom, but where do I assign it? Is there a failure to store because of the bladder or the outlet? Remember the reservoir and the outlet, or a failure to empty because of the reservoir not functioning properly or the outlet. So just to expand this slide, failure to store. The bladder is overactive, involuntary contractions. And I'll just give you a little hint as we get further. This is one of the main problems with Parkinson's disease, is the bladder just decides to go off on its own. Also, decreased compliance, that's not generally a problem, but if someone had radiation for prostate cancer or a terrible infection, the bladder's just not that big, and it just fills and contracts very quickly. Because of the outlet, stress incontinence is common for women who have had multiple childbirths, maybe hysterectomy, maybe postmenopausal, and the multiple childbirths are usually vaginal, not cesarean section, or more likely with vaginal. And then you might have a bladder that is not functional just because of surgery or radiation or some other disease. Now the failure to empty, here's where the bladder is just not working. The bladder is dead. Now, you've seen people who've had strokes and they can't move, let's say, their legs or whatever. You have to remember that the bladder is also a muscle. It's just a specialized muscle. In fact, the bladder is the lowest muscle on your body. If you think about the spinal cord and the segments that go to the bladder, the innervation to your legs is from the lumbar level 3 to the sacral level 1. The innervation for the bladder is S2 to S4. So if you've ever seen one of, I think it's Leonardo da Vinci's drawings where the picture is out, his arms are out like this, but the legs are also out like that. That is really how the neurologic system goes, and the bladder is one of the lowest area. That's one of the reasons why the bladder is often affected earliest in neurologic disease. In fact, there's 2 patients in my career, fairly young women, that came to me, and they had problems with their bladder, and I was very concerned, and I was right because they were both eventually diagnosed with having multiple sclerosis. Their very first symptom was urinary problems. So anyway, we have because of the bladder's not working, or because of the outlet, there's some blockage, prostate's enlarged, or there's something called sphincter dyssynergia. And this is also seen in patients with Parkinson's disease and neurologic disease. The sphincter is the control mechanism in the urethra. And as I told you, the normal pattern of urinating is the bladder contracts and the sphincter or the outlet opens. This is a case where the bladder contracts, but the outlet also contracts. So the bladder's trying to expel the urine against the sphincter that is doing the opposite of what it should be. It's closing down. So here's the urodynamics. And this is water going in, and we have a catheter in the bladder. We have a catheter, in this picture it's in the vagina, but often we put it into the rectum. We put little electrodes around the anus, and you're hooked up to a computer. We do all types of different studies. The 8 C's of urodynamics. And no, that wasn't my grade point. So there's filling and storage things. We look at the contractions as the water is going in. We look to see how does the bladder accept the filling. Does it comply? In other words, does it stretch? Does it allow a lot of water to go in? We assess when a patient coughs, if they're leaking or not. We want to get the capacity. Most patients have about a capacity of anywhere between 13 and 20 ounces of urine. And then we also want to find out what's their sensation. Do they feel that they are getting filled? Because a lot of people, when they have neurologic disease, they don't have that sensation. Just like diabetics don't have sensation in their feet, sometimes people don't have sensation in their bladders. So we want to know about the sensation. That's the filling. The emptying, we want to look at their contractility. Is the bladder able to give a contraction, or is it very spasmodic? Does it empty completely, meaning does all the water we put in come out when they urinate, and is there any evidence of clinical obstruction? So this is how we evaluate all patients with voiding disorders, but especially someone who has Parkinson's disease. Why? Because we want to know, is it an anatomical problem that's common with patients who don't have Parkinson's disease, or is it directly referable to either their Parkinson's disease or the medications they take for the Parkinson's disease? So there's things that we have to do. So here are the findings that we see in Parkinson's patients who undergo these tests. With regard to the bladder, 2/3 have this hyperreflexia. Remember what I told you? Hyperreflexia is where the bladder decides to go off on its own. It's like it's got a mind of its own. In fact, that's what a lot of people say. My bladder, it just goes off. I can't control it. Areflexia is where it doesn't contract at all. And that's a difficult problem. That's a failure to empty, where they can't empty and then they have to be catheterized or some other solution because they're just not emptying. That's a dangerous situation because then you could have problems going back to the kidneys. As far as the sphincter or the outlet, most of the time it's normal. Bradykinesia is just like all of Parkinson's. It's Brady everything. Brady means slow. So, patients move a little bit slower, so on and so forth. But the dyssynergia is where the sphincter or the outlet works against the bladder so that you're not going to have a coordinated cycle of urinating. And that can be annoying because you never empty and you're going to the bathroom frequently and you got to go and it doesn't work. And uninhibited is where it just goes off on its own. So how do I approach patients with Parkinson's disease? Well, first of all, we want to treat the problem that we've identified with the urodynamics or with the history. And we also certainly want to treat the non-Parkinson's Parkinson's disease conditions, which include most common prostatic enlargement in men, stress incontinence in women. Here's the problem, which I addressed a little bit before. Parkinson's is slowly progressive. And at the present time, there's no cure. There's only symptomatic treatment, medical treatment, and non-medical treatment. So even though I would treat the urinary problems and maybe get the patient as close to perfect as possible, 6 months or a year or 2 years later, often the presentation is completely different because the Parkinson's disease may have progressed or they've changed medications or both. I'm a big fan of doing non-medical interventions before we do medical interventions. Most of my patients come and they're not on one medication, they're on 11 medications. And they have dryness, they have constipation, they have everything. So I'm going to try to do non-medical intervention before I start the medications, although we use a lot of medications. But I want to work in a sort of a stepwise fashion. I don't jump to the far end when I know that there are intermediary steps. Timed voiding is one of the most valuable little practices that you can do. What this means is you go on the clock. And I usually have my patients start at 2 hours. And I actually saw a patient today who has a neurologic condition. I started him. What that means is during the daytime hours, every 2 hours, 8 o'clock, 10 o'clock, 12 o'clock, 2 o'clock, so you get up to go to the bathroom. Now, when I want to go to the bathroom, I'm going to be in that bathroom in about 3 seconds. But as I look around the room, there are several people who, when they got the urge to go to the bathroom, for them to get to that same bathroom is going to take them 2 or 3 minutes. And it's in that interval of time where they know they have to go to the time they get there that they leak. Another common thing is the key incontinence. You get home, and as soon as you put the key in the door, you got to run to the bathroom. Hopefully you won't drop the key. So timed voiding is a proactive way of getting to the bathroom before that short interval of urgency occurs where you end up being incontinent. Now, some people can go further than 3 hours. Some people have to go every hour and a half or maybe every hour. But it's a way that you don't need medicine, that you can control yourself, and that gives you some self-assurance as well. Without medicine, that's the way to go. And if this thing's going to go off, you want to be proactive. Now, we do have a tremendous number of medications that are coming out, and I'm going to talk about those in a second. But they're in every newspaper, they're in every TV show, gotta go, all this sort of stuff. It's important for you to pay attention to those, but sometimes when a patient comes to see me, they want this drug. And when I do this evaluation, I find out that that drug is absolutely the opposite that what they should need, because you have to determine, is it a failure to store or a failure to empty? A lot of the medications is for failure to store. But you don't want to treat a failure to store with a failure to empty problem because you just exacerbate it. Some of these other things, we do some surgeries depending on what the anatomical problems. Circumventing the problem, external collection devices. I'm not a fan of the condom or the Texas catheters. I just think that you end up having more difficulty with those, on the male penis than not. I do believe very strongly in intermittent catheterization, if that can be done either by the patient, so it's self-intermittent catheterization, or a caretaker. If a patient still has their, cognitive abilities and their upper extremity dexterity, intermittent catheterization is absolutely positively the safest. Again, to help emptying, there's pharmacologic therapy. Sometimes we have to do surgery. And again, intermittent catheterization, and so on and so forth. I don't want to go too deeply into it, but we want to facilitate here I'll show you either the storage, which is up top, or the emptying. And that addresses the failure to store or the failure to empty. When you break it down very simply in those two areas, it's sort of clear to understand what the problems are. The problems with the medications, the overactive bladder medications, the Detrol, the Vesicare, the Sanctura, the Ditropan, the oxybutynin, and all those sort of things, is they affect a receptor all over the body called a muscarinic receptor. You don't have to worry about that, but look at where they all are. They're in the eye. You get dry eyes, sometimes blurred vision. They're in the mouth. You get dry mouth. In the heart, you can get a fast heart rate. In the stomach, you can get a little upset stomach or heartburn. In the colon, this is one of the worst ones, that's constipation. And finally, oh yeah, we're treating the bladder. Oh, how nice. In addition, there's often central nervous system side effects where it can affect people's cognition. So if you're sort of on the edge, it's certainly not going to help. You can get dizzy or sleepy or impaired memory and cognition. And what's my average patient? My average patient with this is coming in, they're 75, 80, 85. They're on blood pressure medicine, sometimes diabetes medicine, sometimes high cholesterol medicine. They're on antidepressant. They're on medicine for Parkinson's disease. They're on Synthroid. They're on so many things. I mean, every system's got a treatment. And so I'm very, very careful to add another pill. Oh, here, take another pill. And also, the cost of medicine is very high. I happen to be very happy with one of the medications, however, which has been out about a year, and it's a gel. And the gel you just rub on your stomach or your thighs, and it gets absorbed. And the reason why I like that the best is it has the lowest side effect profile. The reason being is the side effects that you see here are mostly from the breakdown product of the drug that you take. So you take this pill, and it goes into your stomach, and it gets absorbed. But where does it go? It goes to the liver, and the liver basically breaks down everything. It breaks down the drug to its metabolites, or its smaller pieces, and eventually it gets washed out. The side effects of these medicines are primarily due to the high side effect. The side effects are due to the higher metabolites. It's the metabolites that cause the side effects, not the active drug. So you take the active drug, it goes immediately to the liver, and it starts already spewing out metabolites which are causing the side effects. The gel is absorbed through the skin into the system, and it goes to the target organ, which would be your bladder, in its active form without being metabolized very much. So it's less side effects. It's very well tolerated. The brand is called Gelnique. I get no money from that, so I don't feel bad if I mention it or not. And I've had a tremendous response with patients who are tired of taking pills and so on and so forth. Does it have any side effects? Yes, but it's less. So that's one I do like. I'm just going to briefly talk about sexual function because I see patients coming in not only with urinary problems, but men with sexual functions problems, and I want to address that as well because if you're still alive and active, you probably want to participate in continuing a sexual life if you have been doing that. I break normal sexual functioning into 5 areas. Again, I like to break things into simplicity. It makes it easy to remember. So you have the brain, which, some of us do, which is your thought and your interest, your libido, and all that sort of stuff. Then you have the spinal cord, which brings all the nerves out, down centrally. Then you have the peripheral nervous system, which brings the nerves to the target organs. You need blood. You need blood to have, an erection is basically just blood into the penis. And finally, what ties this whole thing together in a nice little bow is the hormonal system, which is basically male hormone testosterone. So any problem with any of these areas could lead to poor sexual functioning, or what we call sexual dysfunction. Again, we want to do a complete evaluation, history, physical examination. We do some blood tests. We do testosterone and kidney function tests. Sometimes we do a Doppler, but that's basically not something that we do very commonly. Risk factors. Well, the risk factors for erectile dysfunction are so many, I can't really elucidate all of them. Here's neurologic disease and injury. But here, medications, surgery. One of the big ones is smoking or alcohol use. And what's interesting about sexual dysfunction, unlike most other diseases, when we go to treat a man for sexual dysfunction, we're not going to treat the cause, because we can't reverse a 40-year smoking history. We can't reverse diabetes or high blood pressure. So what we are going to do is we're going to have a treatment plan that is parallel to the cause. I mean, yes, I want patients to quit smoking and keep their blood pressure good and be on the proper medications. By the way, I never stop another doctor's medications, unless, of course, it's arsenic and cyanide. Then I probably recommend you stop it. But even certain medications that I know are affecting the bladder or the sexual functioning, I'll call the doctor and say, is there another option? But I will never stop those medications, because obviously they're treating something that's very important. So what are the signs of low testosterone? And the reason why I want to talk about this just a little bit is, as men get older, the production of testosterone goes down. And there are a tremendous number of men who have low testosterone who don't even know it. And it's really an area that has not been addressed well. And especially in the Parkinson's disease group, I would think that if you have low testosterone, you would tremendously benefit from testosterone replacement. By the way, testosterone does not cause prostate cancer. It can make prostate cancer grow if it's present, but it does not cause prostate cancer. But the symptoms of low testosterone include low sex drive, erectile dysfunction. Here's what's important for Parkinson's disease: reduced muscle mass and strength, possibly some difficult concentrating, over a long-term decreased bone density, making you susceptible to bone problems or fractures, even depression or fatigue and apathy. And so here's some of the benefits: enhanced energy level and mood, increased lean body mass and muscle strength, decreased total body fat. It can improve sex drive and erectile function, and increases bone mineral over a period of time. Are there problems? Well, you can have sleep apnea. Those are usually in patients who are overweight. Very unusual to cause breast discomfort or increase red blood cell count. Does change your blood cholesterol, but sometimes in a beneficial way. It can increase prostate size, and it may impair sperm production, so we generally don't give it to someone who's in a child-rearing age. But the benefits are huge. And I have a tremendous number of patients who are on testosterone replacement. They don't care about their erectile functioning, but these guys feel great. And it takes a while. It takes a good 6 months to really improve dramatically. But for patients who are starting to get weak, the Parkinson's is starting to get a little bit more progressed, certainly to have a testosterone checked and discuss it with your physician and possibly undergo replacement. Also, either with an injection, but they also have a gel like I described on the other one. The benefits way outweigh the disadvantages. And there's really no downside for like a 6-month trial. If you don't like it or there's a problem, you can stop it. But it's really a tremendous benefit. Briefly, I talked a little bit that we don't target the cause of the erectile dysfunction. I use what I would describe as a treatment ladder. I go from least invasive to most invasive. We start with thinking about testosterone replacement. Most of you, if not all of you, have heard about the Viagra, Levitra, and Cialis. There's such a thing called the vacuum erection device. Then we do injections, which is probably not good for those who have neurologic disease, because you have to be very careful where you do the injection. And finally, a surgery where we put in a penile prosthesis, which is really the gold standard, but most people don't want to end up with surgery. They're able to go, they'll say, oh, I'll go to here or to here to here, but I don't want to go any further. And that's one thing that I don't push them for. And I think that's it. I hope I gave you some good information in a short period of time, and I will try to stay for some questions later. So thank you very much.